All right, guys. Hi, guys. Good evening. Good evening. Good evening. Can you all see me? Can you all hear me? A quick feedback on the chat box. Hi, guys. Good evening. Good evening. Good evening. चलो तो the last BLS class on Monday जो हमने बात की थी, we spoke about the management of gastric cancers. I told you about two beautiful surgeries which are nothing short of being an artistic. एक हमारा ruin by gastro, I mean esophagogynostomy था, दूसरा ruin by gastrogynostomy था. I hope you understood what were the core concepts behind it. Hi Akshara, hi Sumit, hi Prince, hi Anshul. Good evening, guys. Good evening. चलो, so we'll be talking about the last topic in the stomach today. तो आज हमारा stomach खत्म हो जाएगा. Esophagus से शुरू किया था, esophagus खत्म हो गया. Now we will be going into stomach और फिर stomach भी खत्म कर देंगे. ठीक है? तो आज stomach का आखिरी दिन होगा in terms of discussion. लेकिन सवाल जवाब चलता रहेगा. Whenever you have any questions, any queries, you know where to ask us. Keep posting us questions. ठीक है? चलो. तो आज मैं बात करूंगा एक बहुत ही peculiar topic की, which is गैस्ट्रिक वॉल्वुलस. ठीक है, तो आज हम डिस्कस करेंगे कि ये गैस्ट्रिक वॉल्वुलस है क्या. So we're talking about the gastric volvulus. When you look at the word volvulus, पहले तो ये समझ लेते हैं कि ये वॉल्वुलस होता क्या है. ठीक है बेटा, एग्जाम कब होगा बेटा? आई विश आई कुड हैव नोन द डेट्स. अभी तो नहीं पता बेटा. तो गैस्ट्रिक वॉल्वुलस में ये वॉल्वुलस क्या चीज. Now, volvulus is best defined as any organ or any loop of bowel, basically. We say a loop of bowel, a loop of bowel that rotates around its axis. Any loop of bowel that rotates around its own axis is called as volvulus. आगे चल के हम बात करेंगे. We will have colonic volvulus, we will have sigmoid volvulus, we have cecal volvulus जिसको ileocecocolic volvulus भी बोलते हैं. Volvulus का मोटा मोटा मतलब ये है कि एक loop of bowel जो है वो अपने ही axis के around rotate कर जाता है. In terms of axis, it is usually the attachments that they exist. ठीक है, तो gastric volvulus का भी यही है कि if the stomach is going to rotate around its own axis, this is what we call it as a gastric volvulus. So when you look at the orientation of the volvulus कि ये होता कैसे, ठीक है. So when you talk about the orientation of the rotation, so when you talk about the volvulus in general, I can divide the gastric volvulus, I can divide the gastric volvulus based upon its rotation into two components, right? We can divide them into two components. One is going to be the long axis rotation, another one will be a short axis rotation. One will tell you that there will be a long axis rotation. Another one will be your short axis. One is what we call it as a long axis rotation. Another one is what we call it as a short axis rotation. तो आप बोलोगे सर ये rotation क्या है? ठीक है. Now you take this as the representation of the esophagus. This is the stomach, and let's say this continues as the duodenum, right? So I'm going to keep both in the same context. You have the esophagus, this is the stomach, and let's say this happens to be the duodenum, right? When you look at the axis per se, I can say the long axis of the stomach. Now I can say this happens to be the long axis of the stomach. So if I have to define the axis of the stomach, I can say that this is the long axis of the stomach, correct? I can say that this happens to be the long axis of the stomach, right? On the other hand, if I have to say what is the short axis, I can say that this is the short axis of the stomach. Okay. So we have both the axes which are defined. एक आप बोलोगे कि लॉन्ग एक्सेस का मतलब है कि लेंथ वाइज सबसे लंबा एक्सेस स्टमक का will fall through this location. ठीक है, short axis जो होगा वो एकदम transverse होगा. Now if a stomach rotates around this, this is what we call it as a long axis rotation, and if the stomach rotates like this, right, this rotation will be called as a short rotation. एक तो ये ऐसे घूम गया, it is going to rotate, and another one it flips like this. ठीक है, तो either ways it is going to rotate. अब obviously कॉमन सेंस की बात है, चाहे स्टमक ऐसे रोटेट कर लो या ऐसे रोटेट कर लो, ठीक है, अल्टीमेटली स्टमक इज गोइंग टू गेट फोल्डेड, मतलब यहाँ पे कंप्रेशन हो जाएगा. अगर कंप्रेशन होगा, whichever content that is going to move from the esophagus into the stomach is going to get blocked. ठीक है, तो जब कंटेंट आगे जाएगा ही नहीं तो ऑब्वियसली सिम्टोमेटिक हो जाएगा. तो हमको ये पता करना है कि भाई ये लॉन्ग एक्सिस शॉर्ट एक्सिस का रोटेशन होता क्यों है, राइट. So our objective is very clear that we need to understand why is the stomach rotating in a long direction or in a long axis or in a short axis. That is what the whole objective of this lecture will be. Did you all understand? Quick feedback. Quick feedback. ठीक है, इसी लॉन्ग एक्सिस के रोटेशन को it is given a special name which is called as the organoaxial rotation. This is what we call it as the organoaxial rotation. This is what we call it as the organoaxial rotation. इसको आप बोलोगे mesenteroaxial rotation. It is what we call it as the mesentero or the mesenterico axial rotation. चाहे आप ऑर्गेनो एक्सियल बोलो, ठीक है, चाहे वो मिडसेंट्रो एक्सियल बोलो, चाहे आप लॉन्ग एक्सिस बोलो या शॉर्ट एक्सिस बोलो, बोथ ऑफ देम आर गोइंग टू हैव द स्टमक रोटेटेड इन दिस पर्टिकुलर फॉर्म. ठीक है, now it's our job to understand that why is this happening or what is the basic reason behind it or who is causing all this is an important context. ठीक है, now when we talk about the rotation, obviously depending upon how much rotation it can turn across, we have a component. Remember organoaxial rotations जो है, they're usually more than 180 degrees. Mesenteroaxial rotations are usually less than 180 degrees. That is why if it is more than 180 degrees, it will be associated with complete obstruction. This will be associated with complete obstruction, whereas this will be associated with partial obstruction. This will be associated with partial obstruction. Okay. So organoaxial will be associated with a complete obstruction of stomach, whereas mesentericoaxial are going to be associated with the partial obstruction of stomach, right? It is associated with partial obstruction of stomach, right? Now, in order to understand the cause factorial component, in order to understand the cause factorial component, I can divide the gastric volvulus into further two categories. Now, based upon the context in which the gastric volvulus, based upon the component, the gastric volvulus can be divided into two categories. We have the primary gastric volvulus and a secondary gastric volvulus. Okay, we have something called as the primary or the secondary. Now, the primary gastric volvulus, they are due to anatomical cause. They are due to the anatomical cause. Now, this anatomical cause is basically the ligaments that are holding the stomach if they become weaker. Okay. So, I say the primary one, they are occurs, or I can say they due to the abnormalities in the, when I say anatomical cause, it is abnormality in attachment of the stomach. We'll discuss in a bit. In attachment of the stomach. तो स्टमक के जो अटैचमेंट्स हैं अगर उसमें लोचा हो गया तो उसको आप बोलोगे प्राइमरी कॉज है. ठीक है, सो ऐसे सेकेंडरी कॉज है, इट इज बिकॉज ऑफ, दिस इज आल्सो ड्यू टू एन एनाटॉमिकल कॉज, बट हियर it is secondary to paraesophageal hernia. It is secondary to paraesophageal hernia, or it is secondary to congenital diaphragmatic hernia. Secondary to congenital diaphragmatic. It is secondary to congenital diaphragmatic. It is secondary to congenital diaphragmatic. So this is in the context of gastric volvulus. Okay? This is in the context of gastric volvulus. Now, when we say there is an abnormality in the attachment of the stomach, let's try to understand that what do you mean by these attachments. When talk about a quick recap, obviously you've read in anatomy. So what are the various attachments of the stomach? What are the various attachments? What are the various attachments that you'll find in the stomach? Let's try to understand, right? So let's say this happens to be the esophagus, going to pierce the diaphragm, and this is where the stomach is present. So you can see the stomach will not be allowed to move. It is going to be fixed, right? So what are the structures that we have in order to fix the stomach, right? The first one, there's a diaphragm that is present. So this is how the diaphragm is going to fall across. Okay. Then there is another organ that is going to be present, which is going to be here. That is going to be your spleen. Another organ that you will see here is going to be spleen, right? Okay. Apart from the spleen, you will see there is a loop of the bowel that is going to run from here. The loop of a bowel that is going to run from here. This is going to, the loop of the bowel that is going to run from here. It is going to go in this particular fashion. Then it goes across it. This is going to be your transverse colon that is going to be present. Just for the sake of understanding, we'll erase part of the. So this is the whole arrangement that you have. So what are the various ligaments that you have or various attachment? One attachment that you'll see one attachment that is going to be connecting the stomach, the diaphragm. This is one attachment that you have, right? Then you will see there is one attachment which is going from the stomach covering the spleen. There's an attachment that covers the spleen, right? So this is also attached stomach, and this will now go and attach the diaphragm. But you will see that this whole attachment of the spleen will be continuous. Will be continuous with the transverse colon. This is how this ligament is going to go across. So this is going to attach from the transverse colon into the spleen, then into the diaphragm. Basically, it is not allowing the spleen to fall down. Okay, this is one that you have. Then you have this part of the stomach that is going to be attached to the transverse colon. This part of the stomach been attached to the transverse colon. Then obviously on the lesser side, you have the lesser omentum that is present. On the lesser curvature, you have the lesser omentum, which is also adherent here, and it will keep the stomach in. Now, as you can see, that stomach is held in all directions. Okay, तो stomach को किसी ने ऐसे लावारिस नहीं छोड़ दिया ना, तो सबने इसको बहुत जोर से पकड़ा हुआ है बेटा. जो भी है पूरी दुनिया में काम पापी पेट के लिए, तो पेट को ऐसा खुला नहीं छोड़ सकते ना, तो पेट को आपने काफी स्ट्रॉन्गली बांधा हुआ है या पकड़ा हुआ है, और ये सारे आपके अटैचमेंट है. तो ऑब्वियसली इन सबके नाम तो पता होने चाहिए, राइट? या good evening, Kunal. Sir, when will abdomen surgery module complete? Right now, we are in the stomach. With this, we would have finished 50% of the stomach. If you have taken hernia also, we have finished hernia before. Okay. So, we have done esophagus. We'll be completing stomach today. We have already done the hernia. then we are left out with only intestines. Okay, the small intestine, large intestine, rectum, and anal canal, and that will be approximately same amount of time that we took for stomach and esophagus. So probably I'm looking for another 2 weeks time, that is 2 to 3 weeks. That is 9 lectures that we are looking at to complete another, I mean the complete GIT. तो पूरे अगले 9 lectures में पूरा GIT खत्म कर देंगे. ठीक है, चलो. Now when you look at this attachment that you can see, which is connecting diaphragm to the stomach, this is what we call it as the gastrophrenic, the gastrophrenic ligament. Okay. So if this ligament gets weaker, the stomach can twist. Okay, so that is one reason that you can have. Then you have the one that is attaching between the spleen and the stomach. It's this attachment that you can see between the spleen and the stomach. That is your gastrolineal ligament. Okay. So that is your gastrolineal ligament. Then you have one that is going all the way from the transverse colon to the spleen, then to the diaphragm. This is what we call as the phrenocholic ligament. फ्रेनो का मतलब डायाफ्राम, के कोलिक का मतलब कोलॉन, लिगामेंट तो लिगामेंट है. तो फ्रेनोकोलिक. फिर आप देख रहे हो दिस वन लिगामेंट व्हिच इज अटैचिंग द ट्रांसवर्स कोलॉन टू द स्टमक, or attaching the transverse colon to the stomach, and this is what we call it as the gastrocolic. This is what we call it as the gastrocolic ligament, and this happens to be a lesser omentum. This happens to be your lesser. Yeah. So these are the various attachments that you have. Now my context is ki if any of these attachments are going to get weaker, or at least say one or two attachments gets weaker, it stomach will lose its comprehensive attachment. मतलब इतना जो strongly adhered stomach है वो नहीं हो पाएगा, and stomach will twist around. ठीक है, या तो यहाँ पे defect है, that is your paraesophageal hernia, or these are defects. If the defects are there in any of these ligaments, then I would say it's a primary gastric volvulus. If it is, the defect is around here, that is around the diaphragm where it is piercing, then I can say it is probably secondary gastric volvulus. Okay, so this is where it is piercing the diaphragm and then entering into the abdomen. Okay? This is how it is piercing the diaphragm and then entering into the clear. So this is with respect to various attachments of the stomach, and as you dissect it down, I mean as you understand, you will get an idea कि अगर इनमें से कोई ligament weak हो गया तो stomach अपने आप twist और turn हो जाएगा और उसी को आप gastric volvulus बोलते हो. ठीक है, is that clear? Is that clear? Quick feedback. ठीक है, तो ये आपका प्राइमरी और सेकेंडरी कॉज ऑफ गैस्ट्रिक वॉल्वुलस हो गया. ठीक है, नाउ लेट इट बी any of these cause, how would a patient present it? So the clinical presentation of the gastric volvulus will be defined by a triad which is called as the Borchardt triad. Okay, to talk about a triad, that is what we call it as the Borchardt triad. Now what is this Borchardt triad? Okay, Borchardt triad में अगर आप लॉजिक लगाओगे, out of the two components that we spoke about, remember your long axis is much more common. 2/3 of your entire gastric volvulus are going to be long axis, only 1/3 is going to be short axis. Okay, 2/3 of your gastric volvulus are going to be long axis, only 1/3 is going to be your short axis. ठीक है, तो मान लो just for the sake of understanding कि हमारा जो stomach था तो बेचारा अपने आप ऐसे esophagus के साथ कंटिन्यूटी में था और खाना वाना सब चल रहा था. ठीक है, कोई दिक्कत नहीं थी. सडनली इट इज नाउ रोटेटेड अकॉर्डिंग टू योर लॉन्ग एक्सिस. ये आपका लॉन्ग एक्सिस हो गया, along the long axis is now rotated. Okay, now once it rotates, you will now notice that this part of the stomach which is rotated would have taken at this component, and the other component of the stomach I have to give you in the objectives. you'll see that once it twists, this is how the stomach is now looking. It is now twisted. It is now twisted in this particular. So the axis that we're talking about, obeying the axis. Now it has rotated. Okay, obeying the axis. This has now rotated. So obviously, what will be the problem? The problem is when the patient is going to feed, all that food that is going to go is going to get stuck and it is going to revert immediately back. Okay, one, the patient cannot feed. Second, anything that is present from the duodenum because of this obstruction, even if it wants to go, it will not be able to go. Right? So it is also not happening. Now, what will be the complaint the patient is going to have? Number one, patient is going to have retching. Retching is basically a dry mess. Patient wants to vomit but is not able to vomit because the stomach is not allowing it, is compressing, right? यहाँ पे दब गया, now दब गया तो obviously content निकलेगा नहीं, obviously because of that there will be, because compression of the stomach will cause pain, so there will be presence of colicky upper abdominal, there will be colicky upper abdominal pain, so there will be retching but no vomitus. Dry vomitus है, there is no vomitus that you will see. It is called retching without vomiting. Then you have colicky upper abdominal pain. There is this colicky upper abdominal pain, and obviously because the patient is having such a severe intensity where the patient wants to vomit, not able to vomit, and obviously the compression will cause distal part of the abdomen to distend. So obviously you'll try to put the nasogastric tube to decompress the stomach. The third one is going to be an inability. There is inability to pass nasogastric, inability to pass the nasogastric. There is inability to pass the nasogastric tube. So there is retching, which is dry vomitus. Then you have colicky upper abdominal pain, inability to pass nasogastric tube. All these put together is what we call as Borchardt triad, right? So when we say the Borchardt triad is going to be existent, remember as soon as you see a patient with Borchardt triad, the first immediate step that you will do is to take an X-ray. Obviously in the X-ray you will see distended stomach. You will see there is distended stomach. You can also take a contrast X-ray. You can also see a contrast X-ray. In a contrast X-ray, you will see there is non-passage of contrast beyond. There is non-passage of contrast beyond stomach. There is non-passage of contrast beyond stomach is what you will see in the context of the initial presentation. The same thing if I have to give you on an image, let's take the image here. Now look at the contrast imaging. I've just given you for the sake of understanding. Same, I've given you comparison between the organoaxial and the mesenteroaxial. You can see it is how it is twisted. The contrast is now failing to go anything further. And here you can see it partially flows and stops. Okay? So this is going to be your organoaxial or atlantoaxial. But if in order to make the diagnosis, remember the investigation of choice. The investigation of choice is going to be a contrast abdomen. Now, in a CECT abdomen, you will see a massively distended stomach where the content is not able to move across, stuck at one particular place. So, in a CT, we'll see how the image look like. Massively distended stomach that you have. Have the massively distended stomach that exists, right? Now, based upon the CECT, once you have gotten this, so I'll position the tube under vision and I will do a nasogastric. First step will be nasogastric decompression, non-negotiable. This is an emergency thing that you have to do. Once you've done a nasogastric decompression, now I will see whether the patient is fit for surgery or unfit for surgery. Whether the patient is fit for surgery. When I say patient is fit for surgery, basically we mean more dynamically. If the patient is hemodynamic, if the patient is hemodynamic. On the other hand, if the patient is unfit for surgery, in unfit for surgery, patients are hemodynamically. There is hemodynamic un. So try to understand that how are you going to approach both of these patients. If the patient is going to be fit, then the first logical option is to take the patient for exploration. That is a surgical exploration. Now, in the surgical exploration, you can do both, that is laparoscopic as well as open. You can do laparoscopic exploration or you can also perform open exploration. Now, once you explore it, you identify the site of the volvulus. The first thing to do is to do a detorsion of volvulus. फर्स्ट थिंग जो रोटेटेड है उसको वापस रीरोटेट करके नॉर्मल कर देंगे. ठीक है, तो पहले क्या करोगे, एक्सप्लोरेटरी लेप्रोटमी और लैप्रोस्कोपी गो इनटू द एब्डोमेन, सी द स्टमक इज ट्विस्टेड, रीट्विस्टेड बैक इनटू नॉर्मल. एक बार आपने डिटॉर्शन कर दिया, the part of the stomach, once it has been detorsion, you see whether it is viable or it is a non-viable part of the bowel. The stomach, after doing a detorsion, whether it is viable or whether it is non-viable. Now, if it is non-viable, even a small kid will tell you that what you have to do, you have to go resect that non-viable part of the stomach. When I say non-viable, that means there is presence of strangulation, and this strangulation has now converted into gangrene. Then I'm saying it is non-viable. For these cases, I would go ahead with resection with anastomosis. For these cases, I would go with resection with anastomosis. If it is viable, that means you don't need to worry, but then you have to look for, is there any secondary cause? You'll see, is there any secondary cause? The presence of secondary cause or absence of secondary. When I say secondary cause, we're talking about the paraesophageal hernia. Okay? We're talking about presence of secondary cause or absence of secondary cause. If there is a presence of secondary cause, if there is presence of secondary cause, then you have to perform a fundoplication. That is a paraesophageal hernia. If there is absence, then you have to fix the stomach, then you have to do gastropexy. The word pexy is basically fixation. So gastropexy में आप क्या करोगे? There's nothing, right? You have the esophagus, you have the stomach. After rotating it back, this is how the orientation of the stomach is going to look across. Let's say this happens to be the diaphragm that you have. In a gastropexy, I'm going to suture the stomach to the underlying diaphragm, right? This is what we call it as gastropexy, where I'm going to suture, the stomach, the diaphragm, right? I'll suture the stomach to the underlying diaphragm, and this is what we call it as the gastropexy. This is what we call it as the gastropexy. Now, this is if you have in the context of viable and non-viable status in a hemodynamically stable patient. ठीक है, अच्छा अगर स्टोरी आती है कि पेशेंट हीमोडायनेमिकली अनस्टेबल है, फॉर अ हीमोडायनेमिकली अनस्टेबल पेशेंट, for a temporary management, I'm going to address this as a temporary management. We will go ahead for a temporary management till the patient becomes stable. You can do percutaneous endoscopic gastrostomy called as PEG. PEG stands for percutaneous gastrostomy. Now, just to be more precise, how many gastrostomy tubes will you put to stabilize the stomach? Now, how do you do gastrostomy is via endoscopy. I'll tell you. This is the stomach. Okay. Let's imagine that this happens to be our abdominal wall. Consider this as the abdominal wall that you have, right? Now you have to do a percutaneous endoscopic gastrostomy. So I will take the endoscope. The endoscope goes and sits across here in the stomach. I am visualizing from here, right? In a peg tube, what will happen is percutaneously, I will send a guide wire which is going to be under vision. I will see it is coming into the stomach. ठीक है? Endoscope रख लिया, guide wire भेजा, stomach को puncture किया, under the vision you are seeing that it is happening. ठीक है? एक बार ये हो गया. What you'll do is I can now give the gastrostomy tube from here. It will be railroaded onto this, and then this is going to be coming out. So there is this component that you can inflate to stick across here. There is another component which is going to be present here, and this tube sticks. Remember, there has to be two percutaneous endoscopic gastrostomy tubes in order to prevent the rotation from happening again. Okay. So, how many peg tubes? There have to be two tubes that have to be placed. One, it fixes the stomach, and second, it also allows you to feed. Okay. So, it is a temporary maneuver where you're trying to fix the stomach to the abdominal wall, and this is the method which is called as the percutaneous endoscopic gastrostomy. तो एंडोस्कोप रखा आपने, ठीक है, अंदर गए, स्टमक के अंदर देख रहे हो, बाहर से गाइड वायर डाला, वायर को आइडेंटिफाई किया, इसी गाइड वायर के ऊपर आपने गैस्ट्रोस्टोमी ट्यूब डाला, एंड देन यू हैव सिक्योर्ड इट, एंड देन यू आर टेकन आउट. सो इट इज अंडर विजन यू आर डूइंग इट, बट देन इट इज गोइंग टू बी एंडोस्कोपी. ठीक है, दिस इज व्हाट वी कॉल्ड एज द percutaneous endoscopic gastrostomy, right? And this is going to be a life-saving procedure once the patient stables. After the patient, अच्छा इसमें ना in this temporary management when you're doing an endoscope now you will attempt an endoscopic detorsion. You will attempt an endoscopic detorsion. तो आप endoscope से ही इसका torsion निकाल के then you will go ahead with PEG. ठीक है, you'll do an endoscopic detorsion and then you will do this fixation and hence things will be sorted. Clear है? So this is all in all that you should know in the context of gastric volvulus. And this concludes our entire discussion on the stomach. Okay. Chalo, so far any questions, quick feedback, kuch पूछना है, कुछ बोलना है, anything that you want to discuss, feel free to ask. We have completed another very important topic in the Balian love, and that is stomach. So you have done 3 topics in GIT. What have you done? You have done esophagus, you have done stomach, you have done hernia. Great job. कोई सवाल, कोई शक, anything that you want to ask? Quick feedback. बेटा वो गैस्ट्रोस्टमी जो है वो आपके स्टमक को फिक्स कर रही है एब्डोमिनल वॉल के साथ. ठीक है, अब एक बार स्टमक फिक्स हो जाएगा तो वापस मुड़ेगा नहीं, तो इसको फिर से रीरोटेट होने से रोका जा रहा है. दूसरा क्या है, यू कैन ऑल्सो डू इंटरवेंशन फ्रॉम देयर. अगर लग रहा है कुछ ब्लॉक हो रहा है, यू कैन टेक द गाइड वायर एंड डू इट अगेन, डू एन एंडोस्कोपी फ्रॉम दैट कंपोनेंट. दैट्स इजी टू विजुअलाइज इट. मोटा मोटा रीजन ये है कि वापस वो घूमे ना, ताकि वो वापस रीरोटेट ना हो. क्लियर है? हाँ बेटा, इफ द अपर पार्ट ऑफ द स्टमक इज समहाउ यू नो जहां पे टॉर्शन हुआ है, अगर वो वाला stomach is getting injured or it is getting friable, no, and you are not able to feed normally, you can use this percutaneous endoscopic gastrostomy tube to feed. Anything else? कोई और सवाल, कोई और शक? अच्छा, बिफोर यू रैप इट डाउन आई वुड लाइक टू आस्क यू अ क्वेश्चन. एक सवाल ऐसी ना, मुझे मतलब नॉर्मली इट सो हैपेंस इन आवर सर्कल, तो कुछ अदर डिपार्टमेंट वालों से बात हो रही थी तो उन्हें एक सवाल पूछ लिया. तो क्वेश्चन ये था, और बेसिकली मोटा मोटा सवाल ये था कि व्हाट इज द डिफरेंस बिटवीन अ सर्जन एंड अ गॉड. ठीक है, भगवान और सर्जन के बीच क्या फर्क है. मैंने भी बहुत सोचा. तो अगर आपको आंसर पता है, यू कैन कमेंट here or you can tag me on my Instagram also. Let's see if you have the answers for this. I've got a beautiful answer for this. We'll come back to that. If you find it, the question is, what is the difference between a surgeon and a god? It is purely on a very lighter note. Please do not take it as apparent. अगर आपको इसका जवाब पता है, you can tag me or answer on the surgery guide. Okay. So this is that we have on the Instagram. It is by my name, Dr. Sandeep Sirampati. Same thing is there on the Telegram group as well. ठीक है, तो सवाल बस इतना छोटा सा है कि क्या वो एक चीज है, what differentiates surgeon from a god. ठीक है, अगर जवाब पता है, you know where to write it down. Until then, thank you so much. Take care. Bye bye.